Hello everyone, I'm Dr. Abraham from A&E Dermatology Specialist to Uganda, and today I want to take us through one of the commonest disease processes we see in dermatology, that is the drug reactions. And in dermatology, we have to understand this concept because commonly, at least one in every patient you see on a daily, there will be a concern over drug reaction. So if you're working in settings of HIV settings, TB treatment, a patient on chronic care with polypharmacy, you have to be very conversant with this concept of drug reactions. So right away, we shall start the session, and let me share here my screen. So as you can see in this picture, in this setting, we are seeing different pictures, 3 of them, which are okay. So in this picture, as you can see here, starting on the picture on the left, it manifests as a patient having these extensive erosions on the back, covering almost the entire back and the rest of the body. And in the second picture, we see a patient having pustules, erythema, hyperpigmentation, covering the trunk. And in the last picture here, in the corner, we see an individual having these well-demarcated annular plaques with hyperpigmentation. And all this is a spectrum of drug reaction. So this shows you that drug reaction can vary from life-threatening condition to subtle conditions, which can even go unnoticed. So it will be very key for you to identify what type of drug reaction it is, what is triggering medication, and how do you manage that patient to avoid the sequelae, which can be death, post-inflammatory hyperpigmentation, scarring, disfigurement, and the rest. So, drug reaction, we usually look at them as a common manifestation in dermatology, and they contribute to a great deal of patients that we see in our practice. In a study done in French showed that 1 in every 200 patients that sought care in a dermatology clinic were actually having adverse drug reactions. And in another study done in the United States of America, it showed that in the admitted patients, 2 to 3% of them were actually having drug reactions. So these drug reactions usually range from simple, as we've said, to complicated conditions, and the simple exanthems and urticaria drug reactions contribute to the majority of the cases, up to 95%, with a slight female predominancy. And we've seen that in our setting, the common drugs that we usually see causing these reactions include aminopenicillin, septrin, and carbamazepine. So if you're working in settings of a psychiatric hospital, you will see carbamazepine and phenytoin being the common drugs. Patient living with HIV usually give septrin, and people react to the sulfur in these drugs. And then in general, we see patients taking aminopenicillin for different bacterial infections, and all these can trigger drug reactions. So the drug reactions, we can categorically classify them into 3 major groups depending on how common they are. So the common forms, we've said that they're the urticaria and exanthematous eruptions. Then we have the serious reactions that usually have systemic involvement. We can have DRES and then the HIS. So DRES is drug reaction with eosinophilia and systemic symptoms, and then this is drug-induced hypersensitivity syndrome. Then the less common reactions, there are also very many, including fixed drug eruptions, lichenoid, pustular, granulomatous, pseudolymphomatous, acneiform reactions. We have SJS, we have 10. These are less common. However, they also have a great deal when it comes to affecting the life of the patient. So this table tries to describe for you how do you approach a patient that is, if you suspect them having drug reaction, and then what do you do? First of all, you have to look at the history and the clinical characteristic of the patient. And in that case, you want to look and examine closely the primary lesion, because the primary lesion will actually give you which drug reaction to expect. For example, This can be at cardio lesion, so you'll be dealing with an at-cardio drug eruption. They can be exanthematous papules, maybe morbidiform, so that would be like a morbidiform drug reactions. They can be pustules, and you start thinking about AGEP, that is acute generalized exanthema drug reaction, maybe with pustules, and then they can be papuric, they can be bully, they can be vesicles. So the primary lesion in that case gives a great deal of the underlying drug reaction or process. Then you have to look at the distribution and the number of the lesions that the patient has. So if the patient has maybe a few lesions and maybe they're generalized, for example, if it's fixed drug eruption, patient may have maybe 3-5 patches on the body, or they can actually be very many. So that can also give an idea. Then you have to screen and see, do we have involvement of the mucous membranes? Because that is very key, and it will signify the severity of this drug eruption. Because if it's involving the mucous membranes, that means that the whole airway can also be compromised. You can also compromise the genitalia, the anal area. So these can be serious reactions. Then you have to look out, what are the associated symptoms and signs? Is the patient having fever? Is there pruritus? Is there lymph node enlargement? Is there visceral involvement? So that will also give you a picture. Then you can now, after getting the history and examination and associated factors of these drug eruptions, you can now go on and document all the drugs that the patient has been on, denoting their particular time when those drugs were started versus when the reaction occurred. So if the medication was started maybe one day before the reaction came, that may point to a particular drug eruption. If the medication was maybe initiated 2 to 3 weeks or a month ago or 6 months ago, so you can also record that history, and it will give you the correlation. Then you have to note the date of the eruption. When did it occur? When did it start? Then you have now recorded which medication the patient has been on. Then you know the date when the eruption started, so you can now correlate the duration. Is it an acute, or is it a late type hypersensitivity reaction? Or is it an immediate reaction, which can be even maybe non-immune mediated? So that will give you a picture of what is going on. So then, how does the patient respond after removing the suspected drug? If the patient resolves or gets better after removing the suspected drug, then you may think that that drug is a culprit. But if after removing the drug, the patient actually doesn't get better, maybe even just worsens and the process continues, then you may think that the drug that you've removed may not be the culprit. So sometimes it can be a bit more complicated if someone is having multiple drugs they are taking, maybe in cases where you have polypharmacy, the patient is on very many medications, patient is diabetic, hypertensive, HIV, on TB medicine. So you may find that the patient has a cocktail of medicines, and it is very hard to identify the particular cause. So what you do in that case, you have to take your history, know the clinical presentation, then list all the drugs the patient is taking. Then you go and read about each drug and the possible reactions that has been associated with, so that you can now collate and see which medicine may be the most appropriate or most likely drug to trigger your reaction. There's what we also call response to re-challenge. So after taking off the medication, you can introduce one by one and then see which one triggers a reaction. We've seen this in patients that we manage for tuberculosis, where you give the 4 drugs. You are giving isoniazid, pyrazinamide, ethambutol, and rifampicin. So in that case, if someone gets what we call DILI, drug-induced liver injury in tuberculosis, you take off all the medicines, then you re-challenge the patient. After their liver function has stabilized, you re-challenge, you bring one drug one by one. So you can start with rifampicin for 2 weeks. If there's no response, you add in isoniazid, then you add on ethambutol, then eventually you add in the pyrazinamide. So that's what we call a re-challenge. So you take off all the drugs, then you introduce one drug by one drug. Then lastly, then you search the database. So currently we have a book that is published every year. It's called the Elite Drug Eruption and Reaction Database. So it's also accessible online. So if you have the different drugs that you are having, you can search these online databases, and then you know which drug eruptions have been reported with that particular medication. So in this case, you can now correlate and know which drug is the culprit. So these databases are very many, but I love to use the LITS drug eruption and reaction database. It is more comprehensive, and it is annually updated. So it usually has newer medicines, newer reactions, newer data. So when you go to the pathomechanism of how these drug reactions occur, this is further classified. It can either be an immunological mechanism. In this case, can either be type 1 hypersensitivity reaction or type 4 hypersensitivity reaction. We say that in type 1 hypersensitivity reaction, that is usually the one mediated by the immunoglobulin A. And in that case, you have the immunoglobulin E causing the reaction. Usually, these are immediate reaction. You take the drug almost immediately, or in 1 day or 2, you get the hypersensitivity reaction. Then we can also have the cytotoxic drug-induced reactions. In this case, you have cells that form, you have antibody formation against a particular drug component where the drug now acts as the antigen. Then you form cells that will come and then destroy the drug. That is now cell mediated. Then in type 3 hypersensitivity reactions, you have immune complexes, whereby you have the antigen and the antibody of the body, antigen being the drug, forming a complex which ends up being deposited in different body sites, including vasculature and organs like the kidneys, like the liver. Then they trigger a reaction there. We can also have the cell-mediated reaction or the delayed type hypersensitivity reactions, which are usually triggered by or mediated by the T lymphocytes. Then we have what we call the non-immunological mechanisms, and sometimes these ones are predictable. So, for example, if someone takes an overdose of paracetamol, we expect acute liver injury. So that would be a adverse drug event, but in this case, it is an immunological. It is due to maybe misuse of the drug. Then we also have adverse drug reactions, like the side effects of a drug that we usually expect. For example, we see people taking chloroquine, maybe quinine, and then they get itching of the skin, maybe otitis, and then hepatotoxicity, and all these are expected side effects of the drug. Then we can have situations where you have the drug accumulating to give you toxicity. So this applies to drugs that have a very high bioavailability and then storage systems in the body. I'll give an example of a drug like isotretinoin. Isotretinoin is a drug usually used in the management of acne, but it accumulates in fat. So as you're giving your drug continuously, maybe for a different given period of time, the drug is progressively increasing its concentration in the adipose tissue. So at the end of it all, when the toxicity levels are reached, and you end up now with the side effects of the drug because of its accumulation. We can also have drug-to-drug interactions. We know that some drugs are supposed to be metabolized by particular enzymes in the liver, the cytochrome system. So in some cases, some drugs are inhibitors and others are inducers of different enzymes of the cytochrome pathway. For example, you find drugs like fluconazole being an inducer of some cytochrome enzymes, at the same time being an inhibitor of others. So depending on how the drug interacts, you may find that if you give maybe a drug that damages the liver like itraconazole, you're giving it together with another drug, or maybe even just a drink like alcohol that also utilizes the liver, you end up with the toxicity of the drug because of them interacting together. Then some drugs can also cause alteration in the metabolism, and this at the end of it all can give you adverse drug event. And sometimes it is the disease process that can be exacerbated by your drug that you're giving. I'll give an example. So sometimes we give drugs like the biologics that are intended to maybe treat different inflammatory processes like psoriasis. So when you give those biologics like the interferon alpha inhibitors, those drugs will be associated with depressing the immune system. Then now you have exacerbation of other underlying opportunistic infection like tuberculosis, like rheumatoid meningitis. So you end up exacerbating the other underlying disease conditions because of the drug that you're giving. Then lastly, we also have what we call idiosyncratic reactions, which are usually unpredictable, and possibly there's a thinking that maybe they may be due to immune mediation, including disease conditions like DRESS, SJS, and 10, that we try to explain the pathomechanisms, though sometimes it is not well understood how the drug ends up causing the damage. So when we progress to the pathogenesis of these drug reactions, most of the drug reactions that we shall look at here, they are type 1 and type 4 hypersensitivity reaction mediated. So in type 1, we say that it is immunoglobulin E, IgE mediated, and in that case, it will give you things like urticaria reactions, and they're usually immediate. And when you give the drug, the onset is almost in no time. Under 30 minutes or even immediately, someone gets a reaction. So we've seen patients, maybe you are infusing an IV treatment, and as you are still infusing your drug, the patient is vomiting, the patient develops a rash, a fever, all of a sudden. So in that case, it is Ig mediated and it is almost immediate. Then we have type 4 hypersensitivity reaction, being the delayed type, and in this case, they are further categorized into 4 subgroups. We have type 4A. In this case, it's predominantly mediated by T helper 1 and the interferon alpha. Then we have type 4B. This is mediated by the type 2 helper, the T2 helper cells, and its DRESS. And then we have type 4 subcategory C. In this case, it's the cytotoxic cells that mediate this reaction. This includes the SJS and the 10. Then type 4D, usually you have neutrophils helping you to mediate the reaction, and they include the AGEP that we shall look at shortly. So in this table, it tries to summarize for us the different cutaneous manifestations in drug reaction. The first one being exanthematous eruptions. So when you look at exanthematous reactions, those ones are sometimes called the drug rashes. They commonly occur in adults and children as well. And you may find that the time interval between the drug and the onset is about 4 days to 14 days. So that's about within 2 weeks. And usually these ones are mild and mortality is usually 0. And then we have these drugs trying to trigger the reaction. I think the common one in our setting to be the aminopenicillins and the sulfonamides, giving you these exanthematous drug reactions. We can have urticaria drug reactions, and most of them are less than 10% are induced by drugs, and they take about minutes to hours to occur. You give the drug, then the patient develops this reaction. And most of them, they can be induced by penicillin, the cyclosporins, the NSAIDs, and monoclonal antibodies. So the same applies to the anaphylaxis. So you give a drug, someone has a type 1 hypersensitivity reaction to the drug, then they end up getting a reaction. So it's still onset is minutes to hours, and mortality is about 5% because anaphylaxis is more severe. Then you have the fixed drug eruption, and in this case, you find that the onset varies on the type of exposure. If it's the first exposure, it can take about 2 weeks. If it is a re-exposure, less than 2 days. And usually within 24 hours, someone gets a reaction after taking the inciting agent. Commonly seen with eceptrin, NSAIDs, tetracycline, pseudoephedrine, which this is very common in cough syrups and flu syrups, and they are common as over-counter medications. Then we have AGEP, which is acute generalized exanthematous pustulosis. In this case, you have pustules, and it occurs less than 4 days after you have started the drug, so it's also another acute form, and mostly commonly seen in beta-lactams, macrolides, and calcium channel blockers. Then we have a drug reaction with eosinophil and systemic symptoms, the one we call DRESS. So DRESS comes in a little bit later, about 15 or 2 weeks to 40 days after you've given your drug. And sometimes people can end up even dying. 10% of them will die. And we see that it is more commonly seen with the anticonvulsants, like drugs like lamotrigine, allopurinol, dapsone, minocycline, and the rest. Then we have other conditions like SJS and 10. These usually occur about 1 week to 3 weeks after you've given your drug, and commonly seen with sulfonamides and convulsants, NSAIDs, as well as triggers. So if you start with the very first type of this drug reaction, the one we call a drug rash, it's also called a maculopapular, urticaria, or morbidiform drug eruption, but the main name, we call it exanthematous drug eruption. So I love this description because when you look at all the manifestation of this drug rash lies within the name. So exanthematous, meaning you'll have exanthematous eruption, sometimes urticaria, sometimes morbidiform like measles, like maculopapular, which is just like morbidiform. So this is a drug reaction that we usually also call just simply the drug rash. So it will appear as a widespread symmetrical red macules and papules, that is maculopapular, and commonly associated with drugs including diaminopenicillin, sulfonamides, and some anticonvulsants, carbamazepine, and NSAIDs like ibuprofen, ketorolac, and celecoxib. So those drugs can also be associated with this drug reaction. So what is important here is that the onset is about 1 to 2 weeks after you start your offending drug. So this is 1 to 2 weeks after. So if you are to classify it to be like more of intermediate, it's an acute process, but not immediate. It doesn't occur immediately. And in the clinical presentation, you have this maculopapular rash, and typically it loves starting from the trunk and around the neck. Then it will spread to involve the extremities, and sometimes it is mildly itchy, other times it's actually non-pruritic. And in a few cases, you can have patients reporting a mild fever and some systemic symptoms like, body weakness, arthralgias may also accompany that rash. So the mechanism that we see in this drug rash, or what we call the maculopapular drug eruption, is likely immunological, which is mediated by either complex immune complexes or even cell-mediated, involving the T cells, especially the CD4 and the CD8, that cause damage by recruiting the perforins and the granenzymes, leading to keratinocyte death. So in this case, this is what happens. You take your drug. Now, assuming the mechanism is by immune complex, now your drug will cause formation. If this is your drug, so if that is your drug, now your drug will cause formation of an antibody. Now the antibody and your drug will form antigen antibody complex. Now these complexes will now be deposited maybe around the keratinocytes. Now when the immune system comes to identify these complexes, the triggered immune response will end up damaging the keratinocytes in that area. And because you are depositing immune complexes, you will end up with triggering an immune reaction in the site where you've deposited them. But sometimes it is thought that the drug will be directly taken up by the keratinocytes, and then they will process and present abnormal antigens attracting the CD4 and CD8 cells that will end up destroying the keratinocytes as target cells. So usually the treatment in all these drug reactions stop the drug, and it's basically supportive, but in severe cases we can give topical corticosteroids and to try and calm down the inflammation, and then someone will be okay. So it can complicate with the exanthematous drug reaction to SJS, to 10. Sometimes even patients actually end up with systemic symptoms, and then you have the sequelae of the condition. It can be super infected, and you end up with a post-inflammatory hyperpigmentation and the rest. So in these pictures you can see here, you see this background of erythema If I may zoom in, you will see the maculopapular rash, the few macules and papules in this area, which are all erythematous. So that is what we call exanthematous drug reaction. So this is another picture in an African patient. Still, we have this rash. You see these papules, this very morbidiform-like papules and macules, skin-colored. Some of them are erythematous. So as you can see, this erythematous background, like here, or that is erythematous background, and it is covering the neck, the face, the trunk in this patient. So the same picture here also tries to show you a background of erythema, but in African skin, erythema will appear more like hyperpigmentation, or it will be grayish than the red that we see in the white skin. So that's how it will look like there. So we go to the next one, which we call a drug reaction with eosinophilia and systemic symptoms, simply called DRES. So this DRES is also called drug-induced hypersensitivity syndrome in some literature, but it's also called drug-induced delayed multi-organ hypersensitivity syndrome. So all these synonyms help you actually to denote the different presentations that we see in these patients. So that means that if you are to look at the DRES, the drug reaction, they're telling you someone has a drug reaction, that is one, but how is it presenting? This drug reaction has eosinophilia. So that means that when you do a CBC, the patient's eosinophils will be up, and then they will also have systemic symptoms like fever, general body weakness, malaise, plus organ involvement. So that's why in this other synonym, you see it being called multi-organ hypersensitivity syndrome. And then the word delayed means that at least it occurs after some time. So the key points in this is that you have potential life-threatening organ involvement, and it should be very key. And it is not very common, so its prevalence or incidence lies between 1 in 1,000 to 1 in 10,000, depending on the setting and the data that was reviewed. So the most common causative agents in DRES that have been identified include aromatic anticonvulsants like phenytoin, carbamazepine, and phenobarbital, and then the sulfonamide. So for patients who are on anti-epileptic medications, you have to be very careful. And for patients who you start on drugs that contain sulfur, they also usually get this drug reaction. So in this case, we know that the pathogenesis of DRES is a delayed type hypersensitivity reaction that is mediated by the T helper 2 cells. So it is type 4B. So in this case, it has been associated with genetic polymorphism, where individuals have different presentations or different genes that are supposed to mediate drug detoxification in the body. So in this case, since it is a delayed type hypersensitivity reaction, it means that 1, someone has to first be exposed to the drug. 2, after exposure, they will get sensitization. So in the process of sensitization, so someone will take a drug, then the body will now note it as an antigen, process the antigen, then later on re-exposure, the patient will now get the reaction. So in this case, you'll form drug-specific T cells that remain as memory cells, and also interleukin-5 that only wait for re-exposure to give you now the reaction. So it has also been associated with viral reactivation, especially the human herpes virus 6-7, EBV, and CMV. In up to even 76% of the cases, there's a history of viral reactivation. So when we proceed down, how will it present? Now, since in this case you need sensitization, then immune activation, it will take a little bit longer since it is a delayed type hypersensitivity reaction. This simply means that when you give your drug, the reaction will not be immediate. So it will occur between 2 to 6 weeks after you've initiated your drug. So in this case, this is a patient, you give a drug for 1 week, the patient is okay. Then later on, 2 weeks later, after your drug has been taken, the patient presents back with a pustular, with a rash on the body, with a drug reaction rash on the body. So in that case, you have to think about DRES, and they'll have systemic symptoms like fever, they'll have a cutaneous eruption. Then the presentation on the skin can be morbidiform. It can be papular, macular, but in most of the cases, they'll have facial edema or swelling around the eyelids. So other skin manifestations that have been reported include erythrodermic picture, where the entire skin is almost covered with a rash. Sometimes they can get papillary lesions or even pustules, just like in AJ. So the internal organ involvement starts from lymphadenopathy. You have marked regional lymphadenopathy, especially the ones in the cervical and axilla. Then you can have liver involvement in up to 80% of the cases. Then other organs like the kidney can be involved, the heart, the lungs, the thyroid, and even sometimes even the brain again end up with edema in the brain. And in the management, we have to, first of all, you have to take away the medicine. And in that case, you have to give systemic corticosteroids the intention in this case, you want to take control of the reaction and stop it from causing further damage. Then after that, you can taper your corticosteroids to lower doses until when you stop them eventually. Then on the skin, you can also apply some topical corticosteroids to try and calm down the reaction on the skin. So after that, in this case, you need to monitor them for long-term complications that can involve the heart and the thyroid gland. So these are patients that you put on a review, and then you have to do cardiac function enzymes, the echo, the ECG, and then you have to also do the thyroid function test to make sure that they don't get this complication. This is a devastating disease with a mortality rate of about 10 to 20%. So you need to be very serious with it when you're managing DRES. So how do you diagnose DRES? So DRES has been under review by different literature, and they have proposed different diagnostic criteria. But the one that I usually like most is the JESCA diagnostic criteria. So in this case, it has a few features that actually you see even on in the wording itself. So the first picture is that someone should have a maculopapular rash that usually develop more than 3 weeks after you've initiated the therapy. So if you give your drug today, 3 weeks later, the patient gets a reaction, then you come and tick that one is positive. All right. But you said that since it is a related hypersensitivity reaction, the range is between 2 weeks to 6 weeks after you've initiated your treatment. And then 2, someone has prolonged clinical symptoms after discontinuation of the causative drug. So as I told you earlier, is that since this is a delayed hypersensitivity reaction, so when you trigger the immune response, it will even continue you have started it, so it will continue to occur even when you stop the drug. Then someone should have systemic symptoms, and one of them is a fever of above 30 degrees Celsius. So someone has a fever, then that is a plus for them. Then you have liver abnormalities. We said that with systemic symptom, you have also involvement of the internal organs, especially the liver. So if the liver is involved, and then you have elevated ALT of above 100, then that's also another plus. Then someone will have leukocyte abnormalities. If someone has any of the following, if there's a leukocytosis of above 11, if they have atypical lymphocytes, if they have eosinophilia, all these give them a score. Then if someone has lymphadenopathy, we say that in one of the systemic involvement, you have a lymphadenopathy. And then if you can ascertain with a PCR and you confirm there's human herpes 6 reactivation, that is also another score. So in this drug reaction, you can, it is either described as either someone having, if you have all the criteria present, then that is typical. So if someone has the first 5, then you can say that actually this is now confirmatory. If someone has from 1 up to 5, but if someone has less than that, then it is just a probable diagnosis, but you can't rule it out as well because other features come in as the patient presents. Then if you're assessing a patient with DRES, So these are the recommended tests that you're supposed to do. You have to do a CBC with the differential so that you know the level of the level of the same, the level of the leukocytes, the level of the eosinophils. You have to know them because it is actually part of the criteria for their diagnosis. Then you have to do burn, you have to do creatinine, you have to do urinalysis, you have to do liver function, thyroid function, then you have to do glucose because of the systemic involvement. So because sometimes you have the heart involved, you have to do a ECG, the troponin levels, even the baseline echocardiogram to make sure that there's no heart involvement. I told you that even after you treated your patient with DRES, you have to follow them up because of the long-term complications, which include the heart and also the thyroid gland. So all these other tests can also be done depending on how your patient presents. So in these pictures here, so this is a patient of DRES. As you can see here, this is still a maculopapular rash. For it even extends to involve the sores to the eventual desquamation, and it will give you this erythema. So on top of this rash that you see here, we say the rash can be maculopapular, can be urticaria, it can be pustular sometimes, because now that is a pustules. So at the end of it all, this patient has a skin picture plus systemic symptoms. And when you do eosinophils, they are markedly elevated. Okay, so we'll go to the next skin reaction from drug. We call it serum sickness like eruption. So this is commonly seen in children with symptoms including fever, joint pains, and then they usually get a rash, which is either at cardio or even morbidiform. This is accompanied by a lymphadenopathy. This one also occurs about 1 to 3 weeks after the drug has been given. And in this case, it can be differentiated from the true serum sickness because in serum sickness like eruption, someone will not have the hypocompletenemia. So in this case, the complements are okay. When you do the complement levels for each enzyme and protein, everything is fine. And someone has no circulating immunocomplexes, and then there is no vasculitis or even renal disease involvement as it is in the true serum sickness disease. So for serum sickness like eruption, you don't have those three features. So the drugs that have been identified, in this case, we have cefaclor, which is commonly given in children, and then drugs like penicillin, NSAIDs, phenytoin, sulfonamide, minocycline, propranolol have all been associated with serum sickness like eruption. And then the next one is what we call drug-induced cutaneous small vessel vasculitis. So in this case, you are getting inflammation or around the blood vessels because of the drug that you have given. So the patient will present with these papuric papules, commonly on the lower limbs or on the lower extremities, and sometimes they can have urticaria lesions. We remember we've discussed about urticaria. So urticaria vasculitis-like lesions, they can have hemorrhagic blisters, they can have pustules, then even necrosis with ulcers. Systemic involvement is rare, but sometimes when it is present, they can have a fever, joint pains, and even headaches sometimes. So this type of drug reaction is usually mediated by type 2 hypersensitivity reaction mechanism, the cytotoxic type, or sometimes it is type 3, what we call the immune complex mediated. And I've explained all those. So it develops about 1 to 3 weeks after you've given your drug, and that's when you get the reaction. So the associated drugs include penicillin, NSAIDs, sulfonamide, cephalosporins, the thiazide diuretics, furosemide, haloperidol, and the rest. The management still involves you to stop the drug, and then you can give systemic corticosteroids. So as you can see in this picture here, so in this picture, we see this papuric plaques that the patient was having on the lower extremities. This was following a drug administration. So these ones can end up being hemorrhagic blisters. They can be and they can end up with the ulcers, necrosis, blistering. So all those other morphological presentations can also be present in this drug-induced small vessel vasculitis. So when we go to the next, where we look at the neutrophilic drug eruption. So in this case, you have the neutrophils involved. That is now hypersensitivity reaction, type 4D. So the first one that we commonly see is what we call AGEP, or known as acute generalized exanthematous pustulosis. So this word also gives you the picture, the clinical picture of the drug reaction itself. One, it is acute, meaning that the onset is very rapid, right? Then it is generalized, covering almost the entire body, and it is exanthematous, and you have pustules in there. So it's also called a pustular drug eruption, or even toxicum, toxic pustuloderma. So in this case, pustuloderma, it will tell you that someone has pustules on the skin, and then it is also toxic. That will give you the picture that it is a drug or something external that is causing the reaction. So the patient will present with small sterile pustules on an erythematous or edematous base. So, and most of the cases, in these cases, you are able to identify the drug. 90% of the cases, you're able to identify the causative agents. And you see that the drugs that commonly cause still include antibiotics, aminopenicillins, and even clindamycin. This time is coming in, the calcium channel blockers, the artiazem, and environmental infections and macular exposure can also give a similar reaction. So in AGEP, we've been and research has shown that it has been associated with particular genetic predisposition, including patients who have HLA, the human leukocyte antigen B5, the DR11, the Q3, and L136RN mutation that has been associated with this reaction. So DRES usually comes in very, very fast. The interval of onset is about less than 4 days. So 1 to 3 days after you've given new drug, someone gets a reaction. So that should remind you that it is an acute process. So meaning that less than 4 days, the patient gets a reaction when you start your medicine. So in the clinical picture, 1 to 2 days, some researchers say 1 to 2 days, you've started a drug, someone gets a pustular edematous rash that oftentimes starts on the face and axilla and the groin, then it will spread to involve the rest of the body. It can present with itching, burning sensation, facial edema, papular vesicles, bully, and the disease course lasts about 1 to 2 weeks, and then it will heal with desquamation. So sometimes you have involvement of the liver, kidney, and the lungs in about 17% of the cases. As you can see in this picture, you see these features of desquamation, like here, this is desquamation. Then you have these pustules that are typical with DRES, if I may zoom in for you. So as you can see here, so these are the different pustules that you will see on an erythematous base. So still in the diagnosis, if you do histology, you will see subcorneal pustulosis, just like in pustular psoriasis. Then the same thing we usually see in other neutrophilic dermatoses, but in this case, you have a drug history, so you can correlate the clinical with the histological findings. So differentials include pustular psoriasis, include 10, even DRES, because we've seen that the DRES can also present morphologically with pustules. So we also have a score. We usually use the validation score that we can also use when you are confirming the AGEP. So treatment, you withdraw the drug, then you can give corticosteroids and then drugs that manage the temperature. So the validation score that we usually use in diagnosis of AGEP, in this case, someone will have different variables, and each variable has or attracts a particular score. So first we look at the morphology of the rash. So if it is pustular, if someone has pustular and it is typical of AGEP, then you give them a +1. But if they're not, it is not very, very, very close, but you say maybe it will give it a +1. If you see that there's no pustular, there's no relation, you can give it a 0. Then if there's erythema and it's a typical one, you give it a 2+. If it's compatible with the disease, +1. If it's sufficient, you give them a 0. Then the distribution. If the distribution is typical, you say that in Egypt, it loves starting from the flexor, the neck, the groin, then it can spread to the rest of the areas. And if it is like that, then it is typical. If it is maybe the pustules are starting on the trunk, maybe lower limbs only, then maybe it's compatible with disease, but sometimes it's just insufficient. It's just a localized, maybe pustular eruption. Then the cause, if there's mucus involvement, Egypt does not involve mucous membrane. So if it is mucus involvement, they get a negative score, -2. And depending on the onset, so if it is acute, yes, less than 4 days, yes, then we give them a 0. If it is maybe chronic, maybe the onset is not acute, maybe after 2 weeks afterward, then they even get a negative mark. If it resolves within 2 weeks, then they get a 0. If it is resolves maybe more than 2 weeks, 6 weeks, then they get a negative score. So if someone has fever above 38 degrees, then they get a +1. If there's no fever, they get a 0. Then if they have polymorphonuclear cells going above 70,000, then they get a +1, because you know that in Egypt, you get neutrophil mediation, so you have a lot of polymorphonuclear cells in your picture. So in histology, if you do your histology and then the histology is typical for any other dermatoses, this gives a -10, meaning that even the diagnosis of Egypt almost disappears, because even the positives are few. So maybe if someone has no if you take off a biopsy, you're not sure, and then the biopsy is telling you features of pulmonary psoriasis, that's now -10. So you drop the diagnosis of Egypt, then you think about something else. So after scoring through this validation score, or the EURO-ESCA study, from the EURO-ESCA study, you can now get the points the patient has gotten. So if someone has 1 to 4 score, then it is maybe possible. If it is 5 to 7, it's probable. If it is 8 to 12, then it is a definitive diagnosis of Egypt, then you can end up managing the condition. So the most frequent drugs that have been implicated in Egypt include the following. So this may be very hard for you to cram, but at least remember, in antibiotics, you have the aminopenicillins, the ampicillin, amoxicillin, the amoxicillin, clavulicus, that's amoxiclav. Then you have the clindamycin, the ceftriaxone, the erythrometro, and the rest. And fungal agents like nystatin, terbinafine, and convulsants, especially carbamazepine, and antimalarial drugs like hydroxychloroquine, antihypertensives like the diltiazem hydrochloride. So those are the common drugs associated with AGEP. So this is how it will look like on a white skin. So you'll see this pustular rash. Okay, so then we go to another neutrophilic dermatosis that can be triggered by drug. So even Sweet syndrome is one of the neutrophilic dermatoses, together with the pyoderma gangrenosum, together with Behçet's disease. So sometimes the Sweet disease or syndrome can be triggered by medication. So it's also called an acute febrile neutrophilic dermatosis. So in this case, it is a little bit rare, and someone will have a fever, painful exanthematous plaques. Usually they'll have fever in the face and then the upper extremities, but also mostly common, also seen on the back and neck. And someone will have a neutrophilic dermoinfiltrate in the skin. Sometimes they can go into the muscles and lungs. So in the peripheral blood smears, we will also see increased neutrophilia, or sometimes may also be absent, especially if the cause is drug. So the common causes, we have hematopoietic growth factors, which includes the G colon-stimulating factor, and then the granulocyte monocyte colon-stimulating factor. So, and the drugs that have been associated with these sweetoid eruptions include the retinoic acid, the ceftriaxone, minocycline, NSAIDs, and then furosemide, together with hydralazine. So in this case, the onset will be a little bit acute. Someone will develop the rash approximately 1 week after the drug has been given, and symptoms will resolve about within 3 days after you stop the drug, and the skin lesions will clear in about a month. So treatment, you stop the drug, give a corticosteroid. So as you can see in this picture, if I may zoom in for you. So in this picture, we see these phytoid lesions that are on the back. They're a little bit wet with pustules around and exanthematous base. So this is how the patient will look like if they get a drug-induced Sweets syndrome. So we also have halodamas, which are either induced by bromide, fluoride, or even iodine. So in this case, someone will get a skin reaction that will be due to exposure to drugs like the potassium iodide, like the amiodarone, and then the contrast media, or even the potassium bromide. These are usually common in sedatives or even used as an anti-seizure medicine. And then also the if you are doing a CT scan, they usually give a contrast that can contain these chemicals. Or sometimes if someone is on supplementation for iodine deficiency, they give drugs that have iodine, and they can also trigger this reaction. So in the pathogenesis, you can have accumulation of these halogens in the tissues, and often if someone has an underlying kidney disease that doesn't allow them to eliminate these chemicals, then this can worsen the condition. So sometimes it will develop quickly within days after you've given the drug, or sometimes it can occur long term after exposure. So in the clinical picture, someone will get an acneiform eruption on the face that will have pustules, sometimes a granulomatous plaques. Sometimes they can end up with ulcer or even bullae. So on histology, you will see neutrophils in the dermis and also epidermal abscesses and papillomatous processes in chronic cases. So the diagnosis has to be differentiated from other forms of folliculitis, even this syndrome, and then also pyoderma gangrenosum. You have to measure the levels of iodine and bromide in blood before you make the diagnosis. If the levels are elevated, then you can have that idea. So the same thing we usually get in factory workers who are exposed to these chemicals in those manufacturing industries, so they can end up with an acneiform eruption. So as you can see here, in this picture, someone has these acneiform rashes with scars and crust at the center, eczema around, and usually the difference is that there will be sometimes they'll start on the face and neck, and they'll spread even behind ears, on the ears, which is usually not typical for the usual acne vulgaris that we see. Then when we go to the next condition, we call it the neutrophilic eccrine hidradenitis, or NEH. So this is a common condition we see in patients who are on chemotherapy. So in this case, someone will have painful erythematous papules and plaques that are caused by neutrophilic infiltrate around or within the eccrine gland. So in this case, the timing is about 1 week to 2 weeks after you've started your chemotherapy, and commonly associated with cytarabine and anthracycline, which is usually used to treat the acute myeloid leukemia. And additional drugs that can give you a similar picture include the methoxythron and bleomycin, imatinib, and then also you can get the same when you give drugs that are granulocyte cone-stimulating factors. So in histology, you see neutrophilic infiltrate around the eccrine glands. So still, you remember this, the wording itself, it gives you that you have neutrophils involving the eccrine glands, causing you the inflammation. So you have the involvement of the eccrine gland. So if it is a papule, that means that it will be interfollicular, not from the air follicle, because the eccrine glands are well arranged between the air follicle. So the papule will be interfollicular, not follicular. So the differentials include other chemotherapy-induced skin reactions. So this is how it will appear like, as if I can zoom in for you. So someone has these erythematous plaques papules that if you magnify more, the papules are usually in between the air follicles. So that is what we call the neutrophilic eccrine hidradenitis. Commonly seen with cytarabine and anthracycline and other drugs that we give in chemotherapy, including bleomycin. So then we go to the next one. So the next one is a very interesting drug reaction because it has a very, very long name. So it is a symmetrical, is what we call symmetrical drug-related intertriginous and fractional exanthema. So in this case, even the name itself tells you where the rash is. So symmetrical meaning that if you see it on one axilla, it's also on the other side. Drug-related meaning that there's a history of a drug administration before the patient develops such eruption. Intertriginous, meaning that it occurs within the intertriginous areas, and then sometimes even also fractional. So that means that the rash occurs in the fractional areas, and it is an exanthema. So it is a symmetrical drug-related intertriginous fractional exanthema. So in this case, someone will have well-demarcated symmetrical areas of erythema that can be in the anogenital region, following systemic drug exposure. So commonly, the triggers include the penicillins, the aminoxicillin, amoxicillin, and then the beta-lactam antibiotics. Then other drugs that have been implicated include clindamycin, radiocontrast media, the H2 blockers, all these drugs like risperidone, they have all been implicated in this condition. So, and the clinical feature, it will typically involve at least one or one other fracture site. So when you have them involving maybe the axilla, then you'll have it also involving maybe the fracture areas, maybe in the neck, maybe in the intergluteal areas, so or maybe in between the on the cubital fossa. So this condition, sometimes it can be confused with a systemic contact dermatitis, and sometimes it can also be confused with the baboon syndrome. So you have to be very careful to tell the difference between all these similar disease processes. So in the differentials, you have to make a clear-cut difference between it and the fixed drug eruption, and then also the toxic erythema of chemotherapy. So which comes when someone has been exposed to chemotherapy. So it also has a diagnostic criteria, and in its diagnostic criteria, we see that someone should have a history of exposure to a systemic drug, and it can occur either whether on the initial or even repeated doses of of this drug. Then someone will have this sharply demarcated erythema of the gluteal or perineal area, and or a V-shaped erythema of the inguinal or perigenital area. Then you should have involvement of at least one other intertriginous site or fracture fold. So that means that if someone has the rash in the gluteal area alone, then you have to think about other things like the baboon syndrome. So, but if someone has that plus involvement of another intertriginous site, like maybe the anticubital fossa, then you have to think about the systemic drug-related intertriginous and fracture exanthema. Then the symmetrical involvement of the areas, so left and right, equally affected, and then absence of systemic symptoms and signs. So in this case, you have a rash, but there's no systemic involvement. Then we continue to the next reaction, what we call photosensitivity. So in photosensitivity, we can have someone getting a reaction because of the drug that you're given. So in this case, the drug can either be a photosensitizer, causing either toxic or allergic reaction. So depending on the reaction, then we can classify it differently, and they're different. So when someone says phototoxic and then photoallergic reactions, these two are very, very different. So in toxic reactions, the drug is directly causing the damage after being activated by the sun. Then in photoallergy, the drug is converted into a photoallergen after exposure to the sun, triggering an allergic reaction. So that is now the different the difference. So starting with the phototoxic reactions, these are a little bit more common, and they are predictable following. So when you give a drug, then someone undergoes sun exposure with UV radiations, then end up with a drug reaction. So in this, in the phototoxic, so you have direct interaction of the UV radiations with the drug, or even its metabolite in the skin. So when then you end up activating the drug, then the drug will cause damage to the skin through formation of reactive oxygen species, which will end up causing cellular damage. So in the clinical feature, it will resemble an exaggerated sunburn, and it should be limited to the sun-exposed area. So we'll have a photo distribution. And in most of the cases, it will resolve with post-inflammatory hyperpigmentation. So in the histology, you'll see necrotic keratinocytes, and then you will see either edema, vasodilatation, and you have sparse lymphatic or lymphocytic infiltrate within the dermis. So less commonly, sometimes you can get even photoonycholysis, where you have the nail bed being separated from the nail plate. This we've seen it most commonly when you give tetracyclines, especially doxycycline, you're managing acne, then someone comes back telling you that their nail plate has started to detach from the nail bed. So that is the photoonycholysis that occurs because of toxicity or the doxycycline. Sometimes you can also get pseudoporphyria, where you get these fragile erosions and vesicles on the dorsum of the hand, which can mimic the porphyria cutaneous. And in this case, someone will have normal plasma porphyrins, but they'll have a picture looking similar to the porphyrin disorders like porphyrin cutaneous. So the common drugs that have been associated in these reactions include the doxycycline, the quinolones, NSAIDs, thyroid diuretics, amiodarone, and the rest. So all these drugs are phototoxic drugs. Then the pseudoporphyria is commonly linked to naproxen, which we commonly don't use in our setting. So the risk that mitigates the reaction include for drugs with a short half-life, usually you can administer them in the evening to make sure that by the time someone wakes up the next day, the drug is out of circulation. So that is one reason why we prefer giving actual doxycycline in the night, so that by the time the patient wakes up the next day to get exposed to the sun, at least the concentration of the drug in the system has also reduced. Then you have what we call photoallergy. Now, in photoallergic reactions, in this case, you have a late type hypersensitivity reaction in response to UV light, which is usually the UVA. So in this case, when you give a drug, this drug is acted upon by the UVA to convert it into a photoallergen that now triggers an immune reaction. So in that case, you get an immune response from a photoallergen activated by the sun. And typically, since it involves activation and the rest, it will occur about 2 to 3 days after sun exposure. So you give a drug, someone takes it, gets an exposure, then the drug reaction occurs about 3 days after the patient even took the drug and got exposed to the sun. In the clinical presentation, someone will have exanthematous or itchy rash that may spread even beyond the areas of sun exposure. So this is usually very typical when it comes to allergic reactions. So allergic reactions, since they're systemic, they're not restricted to a particular area. So the sensitization can occur maybe on the sun-exposed areas, but when the reaction comes, it can even affect bystander skin. So it spreads beyond the photo distribution. The common triggers, we have sunscreens that usually have the oxybenzone, but most the current sunscreen that we are using, this chemical have been, or this chemical has been dropped. So the most current sunscreens don't have this chemical. Then other triggers can include fragrances and certain topical medications like ketoprofen triggering the reaction. Then we go to the next one, what we call the fixed drug eruption. This is part of the bolus drug reactions. So, and in this case, you've seen it having an onset of about a few days to weeks after the drug has been initiated, and it will appear within 24 hours upon subsequent exposure. So someone will present with clinically with the round to oval, sharply demarcated edematous or edematous plaques, sometimes having blisters, with a dark center, or even vesicular presentation, or even erosions. So commonly seen on the face, hands, lips, genitalia, and even mucous membranes can also be affected. So what is peculiar in this case is that every time someone gets exposed, the reaction occurs at the same site. FDE can complicate into a thermomouth SJS, or sometimes even 10. So as you can see in this picture, someone has this well-demarcated plaques with hyperpigmentation. This one has a rash here on the face, on the eye there. So that is how it will look like clinically. So if fixed drug eruption has also been shown to have different variants, dermatology and variants, we are like this. So every disease condition can present in different morphological types, or what we call variants. Or sometimes it can be morphological, can be variant by location. So even FDE has variants. Sometimes you have the non-pigmenting variant. In this case, someone will have the large erythematous plaques, pseudoephedrine or other drugs. And in this case, someone who don't have the hyperpigmentation. Sometimes can also get linear fixed drug eruption. This is a little bit a rare variant. It can mimic the linear lichen planus or the linear lichen striatus and all those linear dermatoses. And histologically, this is a type of reaction that gives you superficial and deep interstitial perivascular infiltrate, majorly composed of lymphocytes, eosinophils, and then sometimes neutrophils. Then you will see these keratinocytes which are dying, or what we call necrotic keratinocytes, that may be present in the epidermis. Then because of the damage to the interface or the DEJ, you can end up having melanin linking into the dermis. Then you end up with dermal melanophages that usually contribute to the hyperpigmentation that we see clinically. So different drugs have been associated with this type of reaction, and these ones usually include antibiotics, sulfonamides, the tetracyclines, beta-lactams, NSAIDs, even paracetamol. So it may be a little bit very tricky to identify which particular drug. And in some cases, you can even find that there's no history of medication. So still, someone can have a single lesions or even multiple lesions, which can also be extensive, and it will give you a picture of SJS and 10. So in the pictures, as you can see here, so in this case, this is now a well-demarcated hyperpigmented patch. So this is the old lesion still occurring at the same site every time the patient gets the reaction, and now this is a blast type of fixed drug eruption. So in the pathogenesis, it has been thought that fixed drug eruption is the type 4 hypersensitivity reaction. And in this case, it involves the activation of the cytotoxic T cells that are activated by the offending drug. And the reactivation has been thought to be due to formation of memory T cells that are left in the same area, like in the same dermal area or in the same area of the skin, that will only be activated when someone gets re-exposure, and they'll cause a reaction in actually the same area. So after getting this homing and formation of memory T cells, they usually remain in the lesional skin, and they only wait for you to take the drug again to become reactivated and cause the same reaction at the same site. So we go to the next dermatosis, that is the drug-related. We have what we call a linear IgA blast dermatosis. We know these blistering conditions. Some of them can be triggered by the drugs, the pemphigus group, the pemphigoid group, they can also be triggered by drugs. So in this case, the linear IgA dermatosis can also be triggered by a drug. So usually someone will get distance vesicles and bully appearing about 24 to 1 day to 15 days after you've started your drug. And clinically, they will form blisters, which can have an annular configuration similar to the idiopathic linear IgA dermatosis. So someone can also present with then-like clinical picture where they have this extensive blistering. And on histology, you will see a subepidermal blister with neutrophilic infiltrate within the dermis. And when you do direct immunofluorescence, you will see linear deposition of IgA along the basement membrane zone, which will now give you the picture that nowadays the drug. So you will have your drug, and then on histology, you will see that kind of picture. So when you do serological investigation, most of the patients, if the drug if it's a drug causing the problem, they will lack serum circulating IgA autoantibodies. Then the resolution usually occur less than 2 to 5 weeks after you've discontinued your drug, and it will not recur unless when you give the drug once again. So the common drug that has been associated with this is vancomycin, and other drugs that have been reported in a few case reports, very many, including NSAID, phenytoin, sulfonamides, antibiotics, the lithium furosemide, amiodarone, and the rest. So we go to the next one, what you call the drug-induced blast pemphigoid. I told you that all the blistering conditions can be triggered by the drug. So in this case, you'll get blast pemphigoid-like lesions, but we'll have a history of a drug causing the trigger. So in this case, someone will get a very, very tense blisters that can affect almost the entire body. Sometimes the lesions can resemble a thermal forming, and sometimes these lesions can just be at carrier. So the common drugs that have been identified, we have the diuretics, NSAIDs, antibiotics, and also other drugs like the anti-PD-1 drugs, or even the PD-L1 antibodies. So sometimes when you do the histology, it will be similar to the autoimmune blast pemphigoid. It's still giving you the subepidermal blistering, but the only difference will be that in this case, it will be the drug that is causing the trigger. And the diagnosis criteria, if you are diagnosing this condition, you have to be very careful because it looks like exactly like the blast pemphigoid that we see in elderly patients. So since it is a drug-induced type of reaction, it can even occur in young patients below the age of 60, whereas the blast pemphigoid, it usually occurs in patients who are much more older, but still you cannot differentiate them clinically. So we can also get the drug-induced pemphigus, because I told you all the blistering conditions can be triggered by it. So in this case, the pemphigus type will still give you the intraepidermal blisters when you do histology, and they will look like the pemphigus foliaceus that we usually see in other in the population. So clinically, it will be similar to the spontaneous pemphigus, and when you do direct immunofluorescence, it will be positive in about 90% of the cases, and circulating anti-desmoglein autoantibodies are found in up to 70% of the patient. So this is a little bit more common, especially in the high-income countries. Up to 10% of the cases of pemphigus may be associated with the drugs. So characteristically, someone will have these lesions appear about weeks to months after starting the drug. So they're a little bit slow and delayed type. And common drugs that have been identified include the thiols, the penicillamine, SE inhibitors, the gold sodium thiomalate, and then also the pyritol. So other non-steroidal drugs include antibiotics, especially B-lactams, and then piroxicam as the NSAID, propranolol, and the rest. So when you stop the drug, usually this one goes away. So still, if you had to look at the picture here, Still, it will look like the pemphigus foliaceous with this superficial blistering with erosions. Since the blistering is so superficial, most times you'll see erosions as the presenting picture. So we go to the next one. The next drug reaction we call SJS, Stevenson-Johnson syndrome, and then the toxic epidermal necrolysis. So these ones, at least people have an idea, because there are some of the conditions that we call dermatological emergency. And SJS has a prevalence of about 1.2 to 5 per million people. And then we have 10, which occurs in about 0.4 per million people. Then someone usually has a problem of upper respiratory tract symptoms like fever, cough, flu-like symptoms, and then a painful skin before they usually eventually end up with the blistering. So these two conditions are a little bit rare and potentially fatal if someone gets them, and they have been associated with different drugs, and characteristically they have involvement of the mucous membranes, which will present as tenderness as well as erythema, and then extensive exfoliation, also the upper part of the skin, the epidermis, after someone has gotten this condition. So the difference between SJS 10 and then SJS 10 overlap is basically the skin surface area that is affected by this condition. So if the skin surface area, that is the denuded skin, if it is less than 10%, then that is Stevenson-Johnson syndrome. If it is between 10% to 30%, then it becomes Stevenson-Johnson syndrome, 10 overlap. If it's above 30%, then it becomes toxic epidermal necrolysis. So this is the picture, just remind you 10%, 30%, and then 10 to 30%, and then the different names that we give them depending on the surface area. So the medications that have been incriminated in this very severe drug reaction include haloperidol. We have also the NSAIDs and antibiotics, including also as well as the aromatic anticonvulsants. So 10 and SJS usually occur about 7 to 21 days after you give your responsible drug, and initially the mortality rate for these conditions, if it is SJS, it may be low 1 to 5%, but if it is 10, it can be as high as 35%, depending on the economy of your country. And the mortality is very high with increasing age and with other comorbidities. If the patient gets 10, they are hypertensive, they are diabetic, usually the outcome may be a little bit worse compared if it occurs in maybe in an adolescent who is in fair condition. So these are the drugs that have been implicated. It may be very hard for you to cram, but when you see, you can cross-check and see if you see this condition, then you can cross-check the medicine that a patient is on, and see if it is one of these. So they usually get exfoliation that occurs due to death of the keratinocytes, and this one occurs via apoptosis mediated by the cytotoxic T cells. And we say that these cytotoxic T cells, that they're destroying the keratinocytes, they have particular mechanisms they employ, including the granulysin or the gran enzymes, and also the interaction with the DES receptor ligand or the fast ligand interaction, ending up with destruction of these cells. So when you diagnose this condition, most importantly, you need to make an understanding that which drug has triggered the reaction, stop the drug, then you have to act quite very fast, because if you don't, the patient can end up losing the entire epidermis, such that they end up looking like Barnes patient. So you need to manage quickly with IV corticosteroids, and then including drugs like IV cyclosporin. If it is available in your setting, then you take down the reaction, you stop the drug, then you can now manage them as the Barnes patient with supportive topical treatments, and then also fluid rehydration. So this table summarizes the treatment. So first, we should have prompt discontinuation of the drug. Then you have to admit the patient, then fruit balance, then you calculate the calorific requirements, the glucose supplementation, then you have to take them for ophthalmic review because this condition also involve the conjunctiva and then mucous membranes. Then you have to do a urologist consult because, again, mucous membranes of the genitalia and then also the urethra can also be involved. Then you can do pulmonary toilet, that is by the physicians and the critical care team. So this is one of the conditions that can lead you into ICU or burns unit. Then in case of IV treatment, you have to consider if it's available, you can give IV immunoglobulins, IV cyclosporin, or IV dexamethasone, or even methylprednisolone. So the differentials can include Rowell syndrome, and then you can also have fixed drug eruptions which have exacerbated, and then also these other drug reactions like DRES. So this is how 10 will look like: toxic epidermal necrolysis with denudation or with loss of the superficial part of the epidermis. Then the next drug reaction, we are almost finishing. We'll call it the acneiform drug reaction. So in this case, someone gets an acute onset of acne-like lesion that's usually triggered by medication. And in this case, you don't have the comedons that we usually see with acne. And sometimes this reaction can be triggered by corticosteroids and then anabolic steroids. These guys who go to gym, they are building muscle, and then they end up with these anabolic steroids. They can get this acneiform reaction. Other drugs like isoniazid, the anti-TB, then lithium can also give you a similar picture. So someone will have these monomorphic red papules and pustules on the chest, back, face, upper trunk, which usually occur a few days, 2 weeks after starting the medication. And in the management, you have to stop this drug and then you treat with benzyl peroxide and then topical retinoids in the night. Then you can also give oral antibiotics in case it is severe, like doxycycline, which can try to calm down the inflammation on the skin. And then we can, the prognosis is usually very good, but sometimes it takes a little bit longer to clear, especially if the acneiform drug eruption occurs in a factory setting. Usually it takes long. So this is how it will look like. It will look like acne without comedons, and then it will be more extensive, covering the ears, the back of the neck, the chest, the trunk, and the rest of the body surfaces. So we can also have drug-induced pigmentary changes. So in this case, they can either be hyperpigmentation or even hyperpigmentation. So in hyperpigmentation cases, we have drugs that usually have been associated with triggering hyperpigmentation. The notorious one is minocycline, that usually gives a blue-black patch on the body, like in this picture here that we can see here. This hyperpigmentation, the patient was on minocycline. So sometimes people can get amiodarone induced hyperpigmentation. Even sometimes antimalarials give you hyperpigmentation for patients who are, like, if they're on chronic care for dermatomyositis, SLE, where we give hydroxychloroquine and the rest, so they can end up with this hyperpigmentation. But sometimes as well, you can be on the other spectrum, on the other end of the spectrum, where you get hypopigmentation. So in this case, we have drugs like corticosteroids, the topical corticosteroids. We've seen them causing hypopigmentation. Even the intralesion triamcinolone, it causes hypopigmentation. And even this biological imatinib has also been associated with hypopigmentation. So usually the mechanism is just simply to interfere with melanocyte function. Then you have reduced melanin production, which sequentially gives you hypopigmentation. So we can also have drug-induced alopecia. In this case, for patients who are on chemotherapy, we see that they usually lose hair. So this is usually due to the chemotherapeutic effect on rapidly developing cells that ends up damaging those cells. So sometimes patients can be started on chemotherapy antibiotic drugs, and then they get shedding of the hairs, which is usually universal, involving all the hairy body parts. And in this case, we have two types. You have the anagen effluvium or telogen effluvium. So anagen effluvium usually occurs as a sudden hair loss, and it occurs if you damage the hairs that are in the growth phase. So typically, this is the form of hair loss that we see with cytotoxic drugs, the chemotherapeutic drugs. And then the telogen effluvium, usually this is a little bit more gradual hair shedding, and usually occurs in the resting phase, often seen by when someone is on the non-cytotoxic medication. So if it is cytotoxic, it usually affects the hair in the growth phase, the anagen phase. So it will give you the anagen effluvium. If it is the non-cytotoxic drugs, they'll affect the hairs in the resting phase. That will give you the telogen effluvium. So the common cytotoxic drugs that cause hair loss include cyclophosphamide, the doxorubicin, and even retinoids like isotretinoin sometimes can affect and give you this drug-induced alopecia. And then we also have other drugs like the beta blockers, propranolol, oral contraceptives have also been associated with hair loss, but in that case, it will be the telogen effluvium. Then in the management, you just stop the drug, and then usually the hair will grow back. Then you can give topical minoxidil that promotes hair growth. Then we can also have urticaria vasculitis. So in this case, someone will get inflammation around the blood vessels, which is triggered by the drug. So in this case, it will be immune mediated, which can be immune complexes deposited near the blood vessels, causing an inflammatory reaction that ends up damaging the blood vessels. So if someone gets urticaria lesions that last more than a day, then we say this is most probably urticaria vasculitis. We take off a biopsy. If you see inflammation and infiltration around the blood vessels with damage of the endothelium, then you can conclude. But if the biopsy is not supportive, then usually you go back and manage it as urticaria. So sometimes someone will present with systemic symptoms, including fever, joint pains, abdominal discomfort, and all this will be accompanying this type of drug reaction. So it has been seen with NSAIDs, antibiotics like penicillin, ACE inhibitors, and anti-seizure medicines like phenytoin. So this table here, you can actually pause the video and try to look at the different mucocutaneous reactions that we see with the drugs. And then you see the different drugs that trigger them. We have looked at alopecia, we've looked at mucositis, we have looked at extravasation reactions, we have looked at chemotherapy, we have looked at mucosal hyperpigmentation, nail hyperpigmentation, and colitis like in the photosensitivity drugs. So all these reactions, and then you can look at the drugs that have been associated with them. That's a continuation of the other table. Thank you very much. Thank you for watching this long video on drug reactions. I encourage you to subscribe, share with your friends so that they can get the same picture. Thank you very much. God bless you.